All right, welcome everybody. So glad you could join us, whether it's your evening or in the case of people in Australia, early in the morning. We're very delighted to have a wonderful speaker today who I'll introduce in just a moment, who will be speaking about their recent publication in the British Journal of Sports Medicine. And let me share my screen. And here it is, and the title of our presentation today. But before I get going, and it was a suggestion by Dr. Liz Joy, who's joining us today, that we should always do a little bit of promo about what exercise is medicine is all about. So I borrowed some of their slides, and I just want to make sure every time we do a presentation that people on the call kind of understand what we're trying to get at with exercise medicine. So you can see our vision statement here, and it's really making physical activity assessment and promotion a standard in clinical care, and then connecting those patients from healthcare with evidence-based physical activity resources for people everywhere and of all abilities. At the core of what we're trying to do with exercise medicine is really a structural or systems approach. Try and change policies and the way health systems are built to affect standards in care, integrating physical activity assessment, prescription counseling referral into the electronic health records, and then building that bridge of trust to the community physical activity resources to support our patients. Really focusing on the clinical side of things, we kind of follow this expert model that involves routine assessment and screening, then that brief advice and counseling, and the referral of patients to physical activity resources. And if you're not familiar with the expert model, it's highly used in the field of substance use and highly successful. So that's what we're trying to replicate. But as part of that, we need healthcare providers, clinicians, nurses, the whole team to really understand physical activity and behavior change. And so that's why topics like today and understanding what are the key things that our healthcare providers need to know in order to implement the expert model in their system. So what we're doing here at the Exercise is Medicine Research Learning Collaborative is we're trying to bring together peers. We have already 15, 20 people on this call. We have over almost 400 people on our listserv to share their practices really around research. And how do we do research in this space of integrating physical activity into health systems? So we're really focusing on dissemination, adoption, implementation, adaptation of best practices, a little bit less on the effectiveness of physical activity. I think we know that when we get people moving, good things tend to happen. So we're trying to increase that capacity and connectivity of researchers in the US and all around the world. There's a lot of good work going on, and we're trying to, as much as we can, share it and be a resource for everyone. So if you ever need, please just Google search EIM RLC, it'll come up. And we have many resources there, including a reference list of publications. But you're not here to hear me speak. We are here today to listen to a wonderful presentation by Talia Alsop, who's a physical therapist, I just learned, as well as a research assistant and a PhD student in just a fantastic research laboratory in the School of Health and Rehabilitation Sciences at the University of Queensland in Australia. In 1 minute, I'll be turning it over to you, Talia. But just one last slide on the format for everyone. The presentation is usually about 30 to 40 minutes long. We really want to have a great discussion and Q&A section. This isn't meant to be a didactic session. So please put things in the chat room, start conversations. I'll help moderate at the end. But really the best part of this all is hearing what you all think at the end and sharing ideas with each other. So with that, I'm going to turn it over to you, Talia, and the floor is all yours.
Lovely. Thanks, Mark. I'll just share my screen. And can you see my slides okay there now?
We can.
Great. Lovely. So Mark's already given a bit of an introduction of who I am, but I'm a PhD candidate and physio at the University of Queensland here in Australia. My research more broadly investigates movement behaviours, In particular, I have an interest in physical activity and sedentary behaviour in the inpatient setting, and in particular in inpatient neuro rehab, and that's sort of my clinical background. But in part of that work, I've started to explore this side of the health professional influence on patient behaviours, because I've realised how pivotal that multidisciplinary team is in the inpatient setting and then in all healthcare settings, in being able to support effective physical activity and sedentary behaviour change with our patients. So today I'm very grateful to be able to share with you our recently published Delphi study. And I'm presenting today on behalf of my joint first author, Emily Lehman, who's another PhD candidate here at UQ, and the fantastic research team who I've got listed here. So the objectives today are really to share with you the study process and the findings, and also just to talk through a little bit about our experience with using a Delphi method. So here in Australia, it's important for us to provide an acknowledgement of country, to acknowledge the traditional owners and their custodianship of the lands in which we live, work and play. So although this work did take place across a number of different countries from various members of the team, I'd just like to acknowledge today the Turrbal and Yagara people, who are the traditional owners of the land of UQ up in Brisbane, and the Yugamba people, the traditional owners of the land where I am today, which is a little bit south of Brisbane on the Gold Coast. So we pay our respects to elders past, present and emerging. So why did we decide to do this study? So I'm well aware that I'm likely preaching to the converted with this kind of audience, which is amazing. And we are well aware that improving physical activity and sedentary behaviour is a global health priority. So much so that the World Health Organization has called for the widespread integration of physical activity promotion into routine clinical practice as part of their global action plan on physical activity. We know that training does exist and there's some excellent training out there, but something that we noticed was that it can be inconsistent and the standards ill-defined, particularly across disciplines. So we identified that there was a need to define the common skills, knowledge and attributes that all professionals need in order to be able to promote positive movement behaviours. So our research aim was to gain consensus on the key competencies required for all health professionals to support individuals to change their movement behaviour, specifically physical activity and sedentary behaviour. And this is probably an opportunity here for me to note why we decided to use the terminology movement behaviour instead of physical activity and sedentary behaviour. So this is firstly because although physical activity promotion is used a lot in the literature, we really didn't want to neglect sedentary behaviour because, of course, we know that that has its own independent health effects. And secondly, we also wanted a set of competencies that would be contemporary and flexible with the progression of research in this field. And of course, now that we're seeing some countries like Canada moving towards 24-hour movement behaviour guidelines, we felt that these competencies would likely remain a little bit more applicable if we could see that shift towards 24-hour recommendations in the future. So a lot of the terminology here is talking about movement behaviours, but we did ask our participants to think specifically around physical activity and sedentary behaviour. So we opted to do this using a Delphi method. So this is a research method that was first developed in the 1950s, and it was originally actually used in the defence industry, but since then it's expanded for use in a variety of fields, including in health research. And it's essentially a process for gaining consensus amongst people with particular expertise in an area. And it's built on that concept that the opinions of many is superior to the opinion of just one. And it involves a series of iterative survey rounds where the findings from one round contribute to the questions of the subsequent round. So you'll see how I explain some of the methods here, that it does start to melt into the results a little bit, and that is because our methods did shift and change as we got the results back from participants from each round. Broadly, our study involved 3 phases. So we had the initial phase of exploration and design, where we established our steering group and designed the protocol. In the second phase, we moved towards participant selection, which I'll talk about in a moment. And then the third phase was the actual data collection phase, where we ran the 3 rounds, and we did that using a series of online mixed method surveys. So after we'd formulated the steering group and started to put together the protocol, we did that using members of the team who had conducted Delphis before, and we also visited the literature for some guidelines. And in particular, some resources that I've put here that we used were the CREED recommendation, which is essentially the Storyb or the Prisma equivalent for Delphi studies. And we also utilised a systematic review of Delphi methodology from Diamond et al. So these are some great resources if you're looking for to conduct a Delphi, to give you some key criteria to improve the reporting and the conduct of your Delphi study. So a few things in particular that we needed to establish in the protocol was stop criteria. So we explained, we anticipated that there would be 3 rounds, but we set our stop criteria at that either when consensus was reached up to a maximum of 5 rounds. And I'll explain a little bit later on why we needed 2 definitions of consensus here, but it is important in Delphi to have a predetermined concept of how you're going to define consensus. So for our second round, we used measures of central tendency. So we looked for competencies that had a median of greater than 7 on an 11-point scale for inclusion into the next round. And then for our third round, we looked for 80% or above agreement. We also opted for an all-round approach. So this is an approach to manage dropout, which was essentially the decision that we would continue to invite all participants who initially consented in the first round to participate in the subsequent round, irrespective of if they had missed the preceding round. So we had predetermined that we were aiming for a sample size of around 30. So this is more than what's recommended for Delphis of around 10 to 18. But we were looking for quite a diverse sample, and we wanted to make sure that accounting for any dropouts along the way, we could still have some form of representation across different regions and discipline groups and roles. Our inclusion criteria were individuals with considerable knowledge, experience and education in physical activity and or sedentary behaviour within healthcare context specifically. And the way that we screened for prospective participants was by doing some research, so largely based on who were known leaders in the field and looking at what kind of publications were available around the world in the field of physical activity and sedentary behaviour in healthcare settings. And we also had a lot of discussions amongst the steering committee and formulated some draft lists to compile a list of prospective participants. And in doing that, we really did try to build towards having a diverse sample where we had some good representation across different disciplines, what kind of roles people were currently working in, and regions that they lived and worked in as well. The third phase, which was the actual data collection phase that took place using the survey, we collected our data over 3 rounds in the end, and this was using an online mixed method survey using the platform Qualtrics. And we had a couple of benefits of using an online survey. So firstly was, considering the fact that we were trying to target quite a diverse sample, including people from different time zones and geographical areas, we wanted to be able to use a method that would allow for that, which of course, using online methods is pretty common now in a post-COVID world anyway. But we also considered that the type of participants that we were targeting were often leaders in their field. We knew that they were going to be very busy people, and we wanted a method where participants would be able to do the survey at a time and a place that suited them in order to reduce the risk of having people drop out here, versus if we went for a method which is not uncommon in other Delphis to use something like a roundtable event or a mix of focus groups. We wanted to instead have something that people could do within their own time to avoid having to have any issues with scheduling. We also had the additional benefit here of participants remaining anonymous to one another. So we wanted to do this to reduce any biases associated with groupthink and enable participants to be able to provide their independent opinion. So we had participants generate their own unique identifier in the first round to use to log in during subsequent rounds, but we then de-identified their data for analysis. We just needed those unique identifiers to be able to re-email out surveys, which is the way that we did it, but there are other ways to do it if you're doing this kind of subsequent surveys in using specific links for specific participants, but we just opted to have identifiers. I've got a figure here just broadly showing the timeline that we followed. So it took us around 4 months in total for our actual data collection. So we opened up the first round for 3 weeks, and each round after that were open for a period of 3 weeks, where we would then have weekly reminder emails to our participants. Then when the surveys closed, we allowed approximately 3 to 4 weeks for data analysis. So I think our first analysis period between rounds 1 and 2 was a little bit longer, as we had quite a lot more qualitative data to analyze. But then between the second and third round, it was a little bit of a quicker turnaround. And so this is a consideration for this type of study, is that it can be quite time consuming and labour intensive over a short period, given that in order to retain your participants, we felt that we needed to meet some short turnaround time to reduce the risk of people dropping off. So an overview of the 3 rounds. In the first round, we asked a series of open-ended questions, and this was essentially to give our participants an opportunity to tell us what do they think that health professionals need to know about movement behaviour change support. And we used thematic analyses to draft some preliminary competencies, which we then took into round 2, where we asked our participants to then rate their perceived level of importance of these preliminary competencies, and we had a predetermined cutoff for inclusion in the next round, set at that median of 7 that I mentioned before. And then in the final round, we, and I'll explain a little bit why our scaling has changed in a moment, but we asked our participants to rate these competencies for inclusion as a key competency for no health professionals, for some health professionals, or for all health professional disciplines. And we had our percent agreement set at greater than 80% for inclusion in the final set. So I'll start to talk through some of the results and methods simultaneously now. So we identified 63 prospective participants and invited them to take part. And we had 40 who consented and took part in the first round, about 36 in the second round, 34 in the final round. So that was a completion rate of 80%, which we were quite happy with. We had representation of participants from 11 countries. So it was mostly the UK, Australia, and Singapore. We had representation from 8 different disciplines, and I should specify that this was disciplinary backgrounds as well. So we asked them about what kind of role they were working in now, but also if they had any kind of clinical background. So about a third were reported a background in physiotherapy or physical therapy over in the US, and around 15% from medical disciplines, and then kind of 8 to 9% in nursing, 8 to 9% in exercise science, exercise physiology, and then we had a couple of occupational therapists, social workers, and psychologists. Around 60% were primarily working in an academic role at the time that they completed the surveys, around 30% in clinical, and then the remainder were working in some kind of combined clinical and academic role. So the results of the first round, where we'd asked open-ended questions, and our 5 questions were asking what did they think that health professionals, what knowledge did they think that health professionals needed to have in order to be able to support positive movement behaviour change, what skills did they need to have, what attributes, what type of system considerations they might need to be able to be aware of, and then they also just had an open-ended question where they had an opportunity to comment on anything else that didn't fit within those categories. From these, we identified 10 key themes, and then we developed 32 draft competencies based on these. So this occurred with a lot of discussion within the steering committee. We were careful to make sure that in how we were formulating the competencies, we were aligning as best we could with the exact terminology that came from the qualitative data from participants, but discussed how that we could turn them into a competency format. And then we also had an external multidisciplinary clinician working group who reviewed the draft competencies, not so much on the actual competencies themselves, because we did want that data to come from our participants, but on the clarity of them. Did these competencies make sense to clinicians? Would they know what to do with them? In the second round, we then we took these 32 competencies to our participants and we asked them to rate their perceived importance of each on an 11-point Likert scale. And we also provided an opportunity for them to comment on each of the competencies qualitatively if they had any general comments about them. And what we found, perhaps unsurprisingly, was that all 32 exceeded the threshold that we'd set. So every competency was rated on a median of 7 or above. So that meant that it would need to make it over into the next round. So this was quite interesting because it essentially told us that even though if there was something that participants in their initial round 1 open-ended questions hadn't mentioned something specifically themselves, if other participants had picked up on something that had been formulated into one of these competencies, everyone was kind of saying, yep, I agree that that's also important. So it wasn't that they deliberately omitted some of these things. So I thought that was quite interesting in the benefit of this type of study design, that you have that different perspective and then being able to take that back to participants and say, well, here's what other experts say, what do you think of that? And be able to get that group opinion. But, conversely, then we do have the detriment of this kind of the way that we collected our data in the Delphi, in that we didn't have that opportunity for deeper level of discussion to occur amongst participants. And certainly we didn't at this point ask them for any kind of prioritization. So, it was probably not surprising that if we had a whole bunch of people with expertise who literally spend their professional lives advocating for physical activity and sedentary behaviour improvement, that they would rate that any of these types of competencies are really important for health professionals to be aware of. But something that we did notice was in the qualitative data, we were a little bit worried about some of the discrepancies in scoring and what kind of comments were made. So, for example, we were noticing that a lot of our participants were rating, an importance of 10. This is extremely important to be included for all health professionals, which was our research question, but then putting in the comment box something like, but it depends on the profession, or only for physiotherapists, or only for medical doctors. And so we needed to ensure that participants knew that we were asking them for all health professionals. So we were concerned that maybe the way that we had asked the questions in round 2 hadn't highlighted that clearly enough. And so as a result, we decided to redevelop the scale for round 3, because really the aims of this study were to develop a set of foundational competencies that were relevant to all disciplines. So as a result, in the 3rd round, when we took these competencies back to our participants, we instead gave them that 3-point scale where we asked, would you think that this competency should be included for no health professionals, for some health professionals, or for all health professionals? And we had a predetermined set agreement at greater than 80% to be included in the final set. And this narrowed our results down quite a lot and identified 11 key competencies that reached that final threshold of greater than 80% agreement. So these are the competencies that were identified, and these are in no particular order. So all of these met the threshold of consensus that they should be included. And although some did have a higher level of agreement than others, we weren't asking participants to rank them in any particular order. So these are not in any particular order. So health professionals need to be able to take ownership over their role in the promotion of movement behaviour change. They need to be able to recognise that all health professionals have an important role in supporting movement behaviour change, and also be able to recognise how their own movement behaviours can influence their engagement with movement behaviour change delivery. They also need to be able to recognise the multifactorial determinants of movement behaviours. So, for example, the social, behavioural and cultural influences on these behaviours. Health professionals need to be able to contribute to and promote a positive movement behaviour change culture that supports its sustainable integration into wider clinical practice. They need to be able to understand the independent and combined effects of total physical activity and sedentary time on health. They need to be able to explain the importance of physical activity and sedentary behaviour in the public health context, consider the common barriers and facilitators to movement behaviours, support individuals to optimise movement behaviours through effective interprofessional collaboration, and they need to be able to use person-centred approaches to facilitate shared decision-making in movement behaviour change support, and use these effective communication strategies to build therapeutic rapport and facilitate movement behaviour change. So some discussion points about our findings and the Delphi method generally. So something that's important to consider is that the exclusion of other competencies doesn't automatically render them irrelevant. And in fact, it might actually suggest that there's something that's quite topical that has conflicting views that warrants some further investigation. And so I've popped here a table from our supplementary file in the publication, just to show you that although we did have a predetermined cutoff, which you should have within a Delphi, it also depends on your research question as to how fuzzy that cutoff might be, and to use your judgment depending on your question as to whether one should be included. So, for example, for competency 31, this one was only 1% off the inclusion criteria. So we did look at that and discuss amongst ourselves, is this something that we might need to take back to participants? But given the type of scale we used in this round, where we were essentially, we could cut this down into a binary scale of did they agree or disagree, and if we put that into that binary scale, the threshold would definitely be exceeded. That most disagreed, or greater than 20% disagreed, and we felt that that was enough for this particular competency, that it seems that there's enough people who think this should only be relevant for some health professionals, but certainly in other Delphis there is room, depending on your research question, to consider that whether or not you need to take some questions back to your participants about those ones who sit right on the cusp of your threshold. And in terms of these findings, we thought that they were quite interesting, and we were interested to know what health professionals that participants thought should be responsible for that given competency if they were voting this, that they disagree it should be included for all competence for all health professionals, but it does depend on the profession. So in this file, we have a list of who those participants suggested might have a particular role in doing that. So, for example, in using movement behaviour change techniques and strategies such as motivational interviewing, we had 6 participants note that it would be more appropriate for physios to do this rather than all professionals, and 4 mentioned exercise physios, exercise therapists or physiologists, 3 mentioned medical doctors, and so on. So although we were interested specifically in those core sets for all health professionals, this is an interesting table for us, and going forward to think about how there might be some extension of those competencies across different disciplines who may have more of a role in certain aspects of supporting movement behaviour change, which makes sense clinically, that we do know some disciplines tend to take more ownership and perhaps have more opportunity with patients, or have more expertise in specific physical activity intervention. In saying that, our findings do reflect what is well reported in the literature and supported by the World Health Organization, and that Mark was highlighting just earlier there, that it is clear that all health professionals do have some role in promoting positive movement behaviours. So I think I probably am preaching to the converted again in this context, but it does kind of note that we may have to have some challenges in translating that into practice, particularly in empowering some of those professions who may not presently recognise or take ownership over their role, which can then hinder that cohesive interprofessional collaboration that our participants identified was important for health professionals. And that will be, part of the challenge for us going forward in implementing these competencies, to find those advocates across professions to be able to champion the widespread integration of physical activity promotion into healthcare. Some of the strengths of our study. So we did manage to have quite a diverse range of participants, as I'll mention in a moment. Not perfect, but we thought we got a nice spread. And of course, the strength in the Delphi methodology, that we had that group level consensus, which is superior to just having individual level findings. Some of the limitations of our study specifically, we weren't able to analyse stability between rounds because we used a different rating system between rounds. So perhaps in hindsight, we could have anticipated that the findings of round 2, where all of the competencies were deemed important, we might have been able to anticipate those results in hindsight. The other option was that we could have added an extra round to the end there to continue to refine that. Because of the time of year, we opted not to do that. So our final round was taking place almost 12 months to the day actually ago. So this time of year, we were quite worried that we would see a big drop off over that Christmas, New Year's period if we tried to add in another round there. And when we weighed that up to what we could gain from another round, we didn't think that it would significantly change the result. And although we did have some good diversity, we still saw an underrepresentation from the global south. So, Brazil, India, Pakistan, Indonesia, for example, we didn't have representation from, and also some disciplines. So we didn't have any representation from, for example, professions like dentists or speech pathologists or pharmacists. And again, I think this highlights the challenges that we might face in advocating for these competencies to be integrated across disciplines, because there are some disciplines who just won't have a lot of advocates working in this field of research specifically at the moment anyway. So in conclusion, movement behaviours are important modifiable determinants of health, as we all know, and we know that changing these have a critical role in improving individual and population level health, which of course is an aim for all health professionals. So all health professionals are well placed and have a responsibility to support movement behaviour change, although how they might do this will vary. And these competencies common to all health professionals mean we have some common standards to work collaboratively to improve health, and they really form that foundation set of competencies that then there'll be other professions that will have additional competencies to build on that. Our future directions, so we are now, just as the presentation today, disseminating these findings and starting to engage with stakeholders about how we could implement some of these competencies. So talking to some universities and different educational bodies to see how we could get these competencies implemented at the tertiary education level, but also post-graduation. So talking to specialist colleges and things like that. So we can look at how we can implement these into some training for already existing health professionals. And we also would like to find a way to get some input from patients and students on these. So my joint first author, Emily Lehman, is doing a lot of work in the student space at the moment, and we'll look at taking these competencies to get some student perspectives on those. We've also just finished data collection for a survey where I was looking at inpatient rehab clinicians in particular, and we had them rate their self-perceived competency using these particular competencies. So we're in the process of analysing that data now, and we would like to expand that to other populations as well. And then, of course, there will be the translation and evaluation of these uses, these competencies, once they're used in different educational programs. Does it actually, if health professionals are competent in these areas, does it actually mean that they end up going and practicing effective movement behaviour change support? So before we have a bit of a discussion, I just wanted to very gratefully acknowledge all of our participants. So those who consented to being acknowledged are listed here, and they're also published in the paper, and also acknowledge our external multidisciplinary clinician working group who reviewed the competencies, and of course the steering committee and the authors who I'm presenting on behalf of today. So it'd be great to have a chat now and certainly answer any questions or discussion about this kind of work going forward. Would be interested to hear what people are doing in this space.
All right, Talia, thank you so much for that presentation. And I think that was perfect timing and a great overview of the work you did. And having done a similar Delphi process just a couple of years before, I know how much work these can be. So congratulations and kudos to you and your team.
Thank you.
So before I talk too much, I'd love to, there we go. Julia, please jump in with your question.
All right, thanks. Thanks for your presentation. Super interesting. So, I'm physio too, but based in the US, but I'm going to actually ask you a question that's not about the US. I'm thinking about the countries in which competency-based education has already been adopted by some of the health professions. So for instance, in Canada, it's actually the law that the health professions are engaged in competency-based education. And I know that it happens in physio, occupational therapy, dietetics, medicine, nursing, pharmacy, respiratory therapy. These are all groups that have their own competency frameworks. Have you looked to see how some of your competencies are matched or not matched to the frameworks that have been adopted in countries where there is already health professional competency education?
Yeah, that's a great point. So my colleague Emily, a lot of her work is looking at what competencies are already in place across different disciplines. And so she's presently doing a study where she's looked at what kind of competencies and crossover there are in different disciplines. I can't recall if she is looking globally or just in Australia. I have a feeling that her work is just looking in Australia. But I do recall when I had a conversation with Emily about exactly that, is any of this already happening in some professions? There were quite a few professions where there was no mention whatsoever of any type of competency that related to movement behaviour, except in some of the professions that we would perhaps expect. So in Australia, in physio and exercise science, we saw some of those competencies existing. And part of that process of why we wanted to develop a foundational set that could be quite fluid was that we would expect that when people were taking these away and using these competencies, that how they use them might look a little bit different because it will have to fit into existing competencies. And some of them might already be met, and if not, we hope that people would be able to look to these competencies and see what our experts have said is also important to include. So add them in if they're not already existing.
Thanks.
Thanks.
Talia, I have a follow-up question to Julia's, and channeling my inner Jim Salas. I remember him speaking like, if we don't promote and disseminate in not our research, and not just in scientific forums, but in policy and real world settings, nobody else will. So what are the plans, or if any, do you and your team have to take this to health professional organizations to try and advocate for the movement behavior competencies to be adopted or integrated into what they already have? Is there any thoughts to doing that?
Yeah, so last year I worked in the UK for the Office of Health Improvement and Disparities, which is formerly Public Health England. And they have a fantastic program called the Moving Healthcare Professionals Program, which I'm not sure if there's anyone here who's familiar with that. But going over and working in a physical activity clinical champion position there, I really realised that in the UK they have an excellent process in place for trying to drive change in this area with clinicians on the ground by having this program where they had clinical champions, physical activity clinical champions going out to clinicians at their hospitals, in their outpatient clinics, to provide education around how they could better integrate physical activity promotion into their clinical practice. So looking at that model, I think that would be fantastic to see that kind of advocacy take place in other countries. And certainly we don't have anything like that in Australia at the moment. So that's one organisation that we're working with to talk to them about these competencies, and I presented this Delphi, the plan for the Delphi rather in June last year to their undergraduate roundtable event about how we would integrate them at the student level. And then we hope to also look to how we could integrate those to the Clinical Champions program, which is the already working health professionals level. And similarly, one of our Hamish Reid, who's a sports and exercise medicine physician, we have some plans for some talks with different colleges who manage training of post-graduation, but specialty training colleges around the world. So I think trying to use our team and use our networks, and certainly just like today, also we've had some great feedback from participants who are obviously very invested in this field, who are excited to be able to find ways that they can implement the competencies within their own spaces. So really networking and finding opportunities for integration, and certainly within my own area that I work within as well, and health service, having those conversations with clinical leaders about, look, this is what we've come up with, what are some of the barriers to implementing those at the moment, or what are some gaps in our team's knowledge and skills and attributes that we could build towards. So I think really that that networking aspect is our biggest tool at the moment to try and get them on the ground and running, and then we'll try and put in some evaluation methods following that.
Excellent. Anyone else want to jump in with a question for Talia? Well, then I will go to my next question. And I'm interested that, you know, when we all finish a research study of any type, we look back and we're like, wow, if I'd known this when we started, we would have done this differently. What would you have done differently looking back over this whole process and the lessons you've learned from this?
Yeah, I think one of the biggest ones was around the way that we had asked the questions in round 2, where we asked participants to rate perceived level of importance. You know, because as I mentioned, we kind of realised when we got the findings back that they thought that all of their competencies were important, that it made sense because they were the competencies that they had developed out of round 1. So of course they would then go on to rate that, yes, it's very important. So in hindsight, we would have changed that scaling up a little bit, and I think we'd also not anticipated that participants weren't clear that we were asking about all health professionals. So although I'm grateful that we did have that qualitative aspect to be able to capture that and identify it to integrate changes into round 3, if we had known about that earlier, we probably would have changed round 2 altogether, and yeah, maybe been able to have space for an extra round to maybe, you know, develop some competencies for particular professions or something like that. So that was probably one of the biggest things. And then I think probably just more on a practical point, which is probably something that I hadn't considered because I hadn't run a survey like this before, was the use of participant unique identifiers, where we had participants produce them for themselves. We had set that, you know, I think it was that we asked them to set their identifier as something like the last 2 letters of their surname and, you know, the first number of their birthday or something like that. So something that theoretically shouldn't change for participants, but that was a practical finding that we found, that we actually had some quite a few unique identifiers that popped up in the 2nd or 3rd round that we hadn't seen before, and had to do a little bit of backward digging to find out who they were, to be able to look at our demographics properly to see who was answering in what kind of way. So from a practical perspective, we probably would have gone back and had individual track links for each participant so that we could just see where that was coming from, rather than relying on our participants to provide the same identifier back. So just a practical thing there that I definitely learned.
No, that's good. You know, to your first point, when we did ours in our Delphi process, was looking at integration of competencies into the actual training programs, not the professional competencies, but very similar. And what we ended up doing, and we asked people to rank order, and not only rank order, but also we gave them a budget of 100 points, and they had to distribute the points to the most important competencies. Because what we've seen in a lot of this work, and anytime you do survey work, even with non-exercise professionals, everybody ranks everything really high. It's all really important. Okay, well, if you have $100 or 100 points, what's the most important that you'll allocate points towards? And I think, you know, those are little things that we've been learning along the way to try and get people to think more critically about what really is the most important thing, you know?
Yeah, that's a great point. And I think as well that that probably lends to translation a little bit as well, because there will be times when people won't have freedom to add, for example, all 11 competencies into their program for whatever reason. Maybe they've only got scope to add 1 or 2 in at this point in time. So having some kind of system like that, where we did also have some kind of ranking, would be fantastic for that, to be able to say, you know, these are the top level priority competencies that if you can only include 2, here are the 2 that we say. If you've got room for 10, here are the 10 that we say, and so on.
Yeah. Well, in agreement with what one of your findings about the behavior change aspects, that was by far and away the most clear-cut result we got. Is it was, I mean, it was like 30-40% more than any other topic was trainees need to learn about health behavior change before anything else. So, but we were able to quantify that because we put in that like kind of rank ordering and that point system. So, but I mean, I love the work you've done. I love these very general, broad, but still kind of focused categories you come up with. It's really fantastic seeing your work.
Thank you. And yeah, I think that that concept of health behavior change generally is where we'll get some buy-in from other professions as well, is to really sell that idea that, you know, it's not just about physical activity. When we improve people's physical activity, it's got all these multifaceted benefits that that can directly matter to your profession. So finding what those are and supporting that, you know, if you know how to change one health behavior, you can transfer those skills into other health behaviors. And you know, when I do presentations at the moment to groups of health professionals from different disciplines, that's one of the things that I always say, is that you're already probably employing some of these health behavior change strategies. You just don't realize it. You know, behavior change is all around us, but making that really clear, that it's not as difficult as I think what sometimes physical activity promotion gets that bad rap of, that it means you need to prescribe exercise and know how to prescribe exercise and tell people that they need to do this amount of reps and sets. So changing the narrative, that really it's just about supporting people to move a bit more and sit a little bit less, and help to recognize what drives their current behaviors, so that we can help people to improve those behaviors.
Well, I think we can always use a little bit more health behavior change skills, all of us. So Beth, I see you come off mute. Do you have a comment?
I did. I couldn't find my raise hand button. And this is, I'm just curious. It's not necessarily a question for you, Talia. It's for anybody on the call. But do we have any idea how long it would take for, you know, from, you know, the publication of these competencies to actual adoption by accreditation, like higher ed accreditation groups, and then from there, so after they adopt them, I'm guessing there's like some kind of lag between when they're actually implemented. Has anybody seen any research in that area for other competencies or topics, or know how long that process takes?
Well, I think David Goodrich would say in the field of implementation science, 17 years, Beth, but that's not specific to competencies. I don't know if anyone's ever really studied that. I'm not aware of that. Are you, Talia?
No, I'm not from that start to finish process.
I can at least address some of the issue on accreditation, on accreditors in the United States. And the answer is that in the United States, accreditation and competencies are not matched. accreditors are not really looking at competent behavior. They're looking at a set of minimum standards for the delivery of an academic program. And they're not necessarily, they're relying on the program itself to determine what competencies it wants its students to meet in the form of expected student outcomes. The place where that's a little different is medicine in the United States. And again, I can only talk about the US experience and a little bit about Canada because I've done some work there, but the place where that's different is in medicine because of the move toward competency-based education in medical residency programs in the US. And yeah, they are slow. I agree. Right. They are slow, but that's changing because residency education is moving to entrustable activities and competency-based. And I have to say, Talia, I could see your work fitting so beautifully with the entrustable activities and the competency-based approach to education. So I think this is just perfectly exciting and placed in a journal where it's going to get that attention. Congratulations.
Thank you. Yeah, I think certainly in the Australian context, we are thinking that that targeting the accrediting bodies might be a good approach because they tend to inform how university programs are designed. So if we can have that sense of advocacy coming from accrediting boards, then perhaps that would mean that when universities are developing their courses, that they simply need to implement these competencies in order to be able to make sure that their courses are accredited. So I guess that kind of top-down approach, as well as talking from the clinician all the way up to educators as well.
Well, that's exciting, and I'm glad, Julia. Thank you for adding that input on competency-based learning. Beth, thank you for that question. Any last questions here or comments for Talia before we end? Well, Talia, any last comments on your side and pieces of advice that you might give the audience watching this presentation?
I don't know if I have any further advice to share, but beyond what I've already shared. But yeah, thanks so much for your time today. And certainly if anyone is interested in chatting further about if you're doing work in this space or if you've got any ideas or discussion points around how to implement these at your own level, yeah, we definitely love to chat.
Well, Talia, thank you so much for spending time with us this evening or Wednesday morning in your case. And thank you everyone for attending. We will be sending out a recording of this and posting it on our website shortly. We're about to finalize a January topic and just so glad you all were part of this. And thank you again, Talia.
No problem. Thank you so much.